quite a familiar faces as well, and some people I've not met, but good. So I won't bore you with by just keeping on talking. So I'll just give a 5-10 minute update, and then Sam will ask the questions, and probably let's go for a free for all and ask questions and try to clear any doubts if there is available. Yeah. So I'm hoping Simon will, I say that and Simon joins as well. So for people who don't know Simon, most people should know Simon. Simon Slade is a fantastic aplastic anemia clinical nurse specialist based at King's College Hospital. So he is a great resource and a great person as well. So there he's go. Yeah, he's still at work while I'm at home. So that's
hello, guys.
Yeah, there you go. Thanks, Simon, for joining as well. So what I thought is just a couple of minutes of updates so that we talk about where we stand. So obviously, so many new things coming guidelines-wise. A couple of terminology-wise. One is around what is third primary dose versus booster vaccination, because significantly this is confusing because the government has done all these things very, very quickly as well. So announcement came on the 3rd of September indicating that the people who are very severely immunocompromised, which would include patients with aplastic anemia who are on active treatment, and also transplant patients who had aplastic anemia. If they fit into the criteria, they should have a third primary dose, i.e. they have a third dose of the vaccine. And that dose of vaccine could be any type of vaccine, but predominantly they said they would prefer a full dose of Pfizer, even if people have had Pfizer before, or AstraZeneca, or half dose of Moderna. Yeah. But if there is availability, if there is non-availability of Pfizer and Moderna, they can have AstraZeneca. So that's called third primary dose, i.e. you're having the third dose. Yeah. And then within 2 weeks later, the government announced that most people over the age of 50, or the groups 5 to 8 or 4 to 8, if I'm not wrong, should have a booster, which means they have a boosting of the immunity against COVID-19 by having an extra dose. So that is called booster vaccination, while the previous one is called third primary. And they recommended that booster so every patient with aplastic anemia will fit into that category of needing a booster vaccination. And that is technically should be done 6 months after the second dose of vaccine. So the booster vaccine can be done 6 months after a second dose of vaccine, while the third primary dose of vaccine can be done 8 weeks after the second prime. Yeah. So that is where things stand. And booster, again, they are significantly recommending that this is going to be a full dose of one of Pfizer vaccine. The reasoning behind both booster and also the third primary is that people, the research have shown that the immunity starts to decline, i.e. the antibody levels start to decline 6 months, 8 months, 9 months after having had the vaccination. So that sort of means that you need to have a boosting of the immune system to produce more antibodies so that the antibodies can stay subsequently over a period of time. So that is about COVID vaccine. And again, about the flu vaccination, we know that the flu season sort of will start with more sorts of social interaction and other things like that. Unlike last year, when we did not see any outbreaks of flu or influenza, they're predicting that this year there will be more flu, and hence the reason they want to make sure that flu vaccination is also provided. And they've said that you could potentially have flu vaccination together with the COVID vaccination because both are inactivated, not live vaccine, so there should not be a problem. And again, what we'll do is we'll talk about whether aplastic anemia patients can have flu vaccination or should it be avoided. We can talk about, because as you probably know, as of date, of the population of 60 million, 3.3 million have been infected with COVID. And unfortunately, the risk of death, it's about 1% risk of death as well. The one data which we don't have yet is in health, so sort of so-called healthy people. We know the protective ability of the vaccination is around 90-95%. But in aplastic anemia and also in PNH, the data is still being looked at to see what proportion of patients with aplastic anemia will respond to vaccination. If we vaccinate 10 patients, is it going to be 6 who's going to respond, 7 who's going to respond, or 8? The general consensus is that there won't be, the response won't be same as somebody who is sort of healthy within inverted commas, but it won't be like 10% or 20%. My guess is that it will be around the 60-70% mark. Don't ask me why I say that number, but that's probably what I think based upon other data from other immune conditions, cancers, and other things. My guess is approximately 2/3 of patients should respond to vaccination with COVID vaccine. So I think that's probably where I would say I will leave it. I'm happy to take questions which you've submitted via the forum. And I think Sam is going to ask a few questions, and then we can talk around it and give you some clarification of where we stand. There are some of the recommendations which I give today will be based upon evidence and data. Some of the recommendations which I give will be just based on experience from our center in King's. Obviously, there are some questions which I might not be able to answer at all because there is no data at all.
Excellent. Thank you very much for that, Austin. That was really useful. And in fact, that has already answered quite a good proportion of the questions that are already submitted. So excellent. So I think what I'll do, I'll start off with some of the questions that people have submitted about the flu vaccination, and then we can go on to some about the COVID vaccinations, if that's okay. So again, this is a question that was submitted by somebody who is in long-term remission after receiving horse ATG a number of years ago, and they have said more generally, should they be receiving the flu jab this year?
Yeah, so I think for this we have to go back a few years or many years back. I think so. So historically in UK. In the community of aplastic anemia, there has been the issue around flu vaccination predominantly because of a couple of cases of flu vaccine-induced relapse of aplastic anemia, i.e. you get a vaccination with flu, the blood counts are normal, but after vaccination, the blood counts can potentially drop down to lower levels. And this, there has only been 2 cases reported, and this is going back many years now, at least 20 years or 15 years back, I think so. And there has been some anecdotal reports as well that not just flu, any vaccination can trigger the immune system, that there is a potential that the blood counts can drop down or cause relapse of the aplastic anemia. But again, if we ask people around the world with aplastic anemia specialists in other countries, in US, France, and Italy, they do not follow this policy. So they tend to give flu vaccination to anybody with aplastic anemia and are not significantly concerned. So this again throws it back to you. The question is always about risk-benefit ratio, and everything we do in life is about risk-benefit ratio. So somebody can ask, and I think one of the questions was, you always all along said to the aplastic anemia community, don't have flu vaccination. Now you're saying have a first COVID jab, have a second jab, have even a third one, and have even a booster. So why are you changing that bias? And again, that's the risk-benefit ratio, because we have seen literally with everybody in the hospital how fatal COVID can be, and how horrendous these infections with COVID, with SARS-CoV-2 or COVID infections could be, with even with a fatality rate of 1%. So 1 in 100 people who acquire COVID and can get complications leading on to death. Yeah. So that is why we've always said, if you compare the risk of COVID vaccine making your blood counts go down and worsening of your aplastic anemia, compared to the benefit which is offered by the vaccine in preventing severe COVID infection, the benefits significantly outweigh the risk of vaccine induced. And I can definitely say, till date, there is no reports yet of, again, it's something which millions and millions of people getting vaccinated. There is no reports yet that we could see reported in the literature or anecdotally hearing through other colleagues in the world. I've not come across anybody who's had a COVID vaccine and subsequently led to a drop in their blood counts and relapse of aplastic anemia, or aplastic anemia getting worse. Contrarily, we have seen patients who have developed COVID-19 and developed aplastic anemia. In UK, we've seen 3 cases of such, where you develop COVID infection and then develop aplastic anemia, and around 15 patients where they have aplastic anemia and develop COVID, and then the blood counts can go down sometimes significantly, sometimes subtle drop in the blood counts, and then recovery as well. So coming back to the question, because of this anecdotal reports and couple of cases reported, we will always say what is the risk of getting flu and getting complications versus vaccine, and the worry, both psychological and also the potential risk that the blood counts can drop down, makes me worried. I cannot always give you a blanket advice on that. So if you're somebody who think, yes, I'm reassured by that, I'm happy to go for it, that's fine. But if you're worried and saying, this is particularly for the flu I'm talking about, I'm happy to have a bit of flu and lie in the bed and get over it after a couple of weeks. And rather than my worry about blood counts crashing down, then it's totally up to the individual decision. And obviously we can give advice, but important for you guys to take every information in and make the right choice.
Fantastic. Thank you very much for that, Austin. That was a really, really comprehensive answer there, and I'm sure our community will find that very useful. The next question that we have is regarding the live nasal spray vaccine that young people often receive for the flu vaccine. And there's somebody that's asked the question, they're saying that they have aplastic anemia, and they've asked if it is safe for their child to be in school around the time that the flu nasal sprays are being given to their classmates.
I think simple answer is yes. I think so. I don't think so there is any contraindication at all, and unless I'm totally missing the point to the question, but I don't see any issues with that.
Excellent, that's great. And there was somebody else that was asking, how important is it that immediate family members get the flu jab at the same time as the patient with aplastic anemia?
I think generally the recommendation is that if there is, because these vaccines are all inactivated vaccine or killed vaccines, predominantly the ones which are injected. So if that's the case, I don't think so it matters significantly that it has to be done together. Yeah. But if it is mostly sort of in the live vaccine and other things with the potential. So there is, sometimes we recommend to have it together, but it never happens all the time. So you could try it, but not 100% that is necessary.
Excellent, thank you. That's all of the questions that we have regarding the flu vaccination. So now I think it's wise that we move on to the COVID vaccinations, because we have quite a few questions around there. The first question that we have is from somebody who has received a stem cell transplant recently, and they've asked if you have had COVID but are still unvaccinated, as per the advice from the transplant team, how careful should they be in terms of following shielding requirements and social distancing?
Yeah, so I think a slight, just a few preamble to transplant and vaccination as well. So just first dictum is aplastic anemia patients post-transplantation, post-stem cell transplant, should totally follow the advice of transplant vaccination advice. And there is no potential risk of vaccines, even which we were talking about the flu vaccine, potentially theoretically making the blood counts low is non-existent, or we've not seen it. So I think they should follow the vaccine guidance as such for post-transplant vaccine guidance. As far as the vaccine guideline, COVID guidelines is for post-transplantation, it's usually recommended after 6 months, yeah, and also recommended if they are not on a big dose of immune suppression to like if they're on a high dose of cyclosporin or high dose of mycophenolate, which is another drug used post-transplantation to avoid rejection, or if they don't have active graft versus host disease, they would be advised to have the vaccination post-transplantation. Predominantly after 6 months. Even if they had vaccine prior to transplant, if they've completed first and the second dose, after transplant, they need to have a repeat schedule of the first, second dose, third dose, and potentially booster as well. Sam, ask the first part of the question again. I might have missed the first part.
Of course, yeah. This person was saying that although they've had a stem cell transplant and they are still unvaccinated as per the advice, they've actually had COVID before, and I think they were asking about whether they'd have any kind of the natural immunity from it, or whether the transplant would have affected that.
Yeah, thanks for that apology. So what will happen is all your antibody responses, unfortunately, even if you've had COVID before, during the chemotherapy and the immunotherapy during transplant, the antibodies will be totally wiped out, which is another reason people say you need to be vaccinated again. So the risk of acquiring COVID is there, definitely there, despite somebody having already had a COVID. Additionally, we also know that if you've had an alpha variant, there is a potential of having the delta variant and other things, because some of the immunity is protective against both of them, but not totally protective against that. But just as an aside to this question as well, is that if patient didn't have a transplant, if you've already had a COVID, people always say the protection offered by natural infection, but no way to say we need to all get COVID, but the protection offered by natural infection to COVID or coronavirus is going to be at least 3 to 4-fold higher than the vaccine-induced immunity. And sometimes even what will happen is the vaccine will boost the natural immunity which you got against the virus as well. So those are things for non-transplant patients.
Excellent, thank you. The next question that I have is from somebody that's got a little bit of a concern about their child. Again, obviously, I'm not sure about the eligibility for them to receive the vaccine at the moment, given their age, but they have a 15-year-old child who has aplastic anemia, and they're asking about the potential risks that are associated with vaccine for people in that age group, because we have heard, obviously, some anecdotal reports of some complications for people in that particular age group, particularly boys at the moment, and they've asked him about the kind of risk versus benefit ratio for somebody in that age group.
Yeah, it's always difficult as well. And yes, there has been, so technically that person will be eligible predominantly for Pfizer or Moderna vaccination rather than AstraZeneca. There unfortunately has been some reports of cardiac problems, predominantly myocarditis and other things following. Again, if you look at the number of people vaccinated versus the risk, it is low, but still something which people will be concerned about, because these can be quite a significant risk, which is not dissimilar to the blood clots related to AstraZeneca vaccine in people less than the age of 40, because that risk of blood clots is around 15 cases per million, predominantly after the first dose. So again, with the young people having COVID vaccine, it's about risk-benefit ratio as well, because again, even in younger people who, if they have an underlying immune problem like aplastic anemia, if they get COVID and the complications, that is going to be significantly higher than the risk of vaccine giving infections. But the once the people are less than the age of 30, 20, and 10, then the balance can slightly shift as well, because older you are, the benefits of vaccination significantly outweigh the risks of vaccine-induced complication. But sometimes it goes a bit down in younger people, predominantly children.
Excellent, thank you. The next question I have is from somebody that has PNH and also has aplastic anemia. They've said that I have concerns about the blood clotting risk associated with the COVID vaccines, which of course we've heard about in the news recently. Is it safe for somebody with AA or PNH to have the vaccine given this risk?
Yeah, again, individual. I think those kind of individual questions, definitely you need to check with your local team as well, because AAA PNH is obviously a very broader term, and it's also important to see what is the size of the PNH clone, what is the risk of blood clot related to PNH itself, compared to the risk of a blood clot associated with vaccination. But the easy answer would be there has not been any reports of that complication, i.e. blood clots, vaccine-induced blood clot with non-AstraZeneca based vaccination. So the potential would be that you could, if you're less than the age of 40, then the recommendation is to have non-AstraZeneca, so which in UK will be Pfizer or Moderna. So the risk is again, everything is about stratification of the risk and how much benefit would you derive as the complication associated. So I think choosing a different vaccine rather than AstraZeneca would be a good thing.
Thank you. Excellent. The next question that I've had, and this is actually the final one from the ones that have been pre-submitted, is again, this is from somebody that has received a stem cell transplant. How long after transplant is somebody considered to be at increased risk of becoming unwell with COVID?
Oh God, how long is a piece of string, is it?
Of course.
I think unfortunately the risk of I know where the question is from. No, I think the risk is about. I think the risk reduces as time goes on, but unfortunately, everybody is at risk of acquiring COVID. It's just a question of complications, and that depends upon how your immune system has recovered post-transplantation. So, if somebody has got a graft versus host disease, then their risk or their immune system is going to be slightly definitely impaired, so their risk of complications could be higher. If they are on cyclosporin or other drugs to suppress the immune system, their risk of complications could be higher. The older you are, the complications are higher. If you have other things like diabetes, obesity, high BMI, and other medical conditions, the risk could be higher as well. So I think it's relative, and I think as many people say, we have to sort of try to live with this virus now rather than try to overcome it, and we just need to have strategies to manage it.
Excellent. Somebody's also asked as well, this is one that's just come in by email actually. Somebody said, and again, they are a transplant patient, but this could equally apply to somebody that's living with AA that hasn't had a transplant. What should they do? What would your advice be if they were to test positive for COVID? Should they immediately head for hospital, or what would the advice be for a patient that's tested positive?
I think if you test positive, it always depends upon the symptoms. Yeah. So if you remain asymptomatic, so it's important to monitor for symptoms for at least a period of a week to 2 weeks. Minimum, I would say 2 weeks. How you feel? Are you able to do things like predominantly around the breathing? Yeah. Because with the COVID, there is always there is a second response. People say that patients tend to slightly get more fever and temperature after 7 days. They have a second peak between day 7 and day 10 when they get a temperature. So it's mainly a question of regularly monitoring the temperature, making sure your breathing is okay, trying to do a few things to see whether you don't feel out of breath or not, sort of going up the stairs or something, just to check whether how much does that affect you. Loads of people sometimes have bought their saturation monitors to check how much oxygen levels are there. So a temperature, a saturation monitor, those things are important to just carefully monitor it to make sure you don't need to be too worried as well, but you don't need to be leave it too late as well. So you need to monitor. Unless the breathing is affected, the temperature does not settle, or you develop other symptoms, there is no rationale for going to seek medical advice, because the treatments are only given for patients who have those symptoms or oxygen levels are reduced.
Excellent. Thank you very much for that. I'm sure our community will find that incredibly useful and reassuring. We've just had a question in the chat from Mandy. Hi, Mandy. Mandy has asked, how long after transplant should a person be considered as a priority for having an extra third dose of the vaccine? And at what point would that dose transition from being classed as a third primary dose to a booster dose?
Yeah, so that is a bit confusing because they've not given a clear indication. Yeah, so my guess is that they should all have third primary dose, because the so once your transplant team has said yes, you can go ahead with your first dose, second dose, then definitely they need to have the third primary dose. Yeah, and then after the third primary dose, the booster is classified after 6 months. Yeah. So first dose, second dose, after second dose, 8 weeks later, third primary dose, and then 6 months later is the booster. If I understand the statements from JCVI and the government, that is my understanding.
Excellent, thank you. Thank you for clarifying that. We've also had another question that was with regards to the advice what people should do if they test positive for COVID. Somebody's asked, would that still apply if somebody was neutropenic?
Yeah, I think if you're neutropenic, I think the main thing is you shouldn't think that if you're neutropenic and get a COVID, you should not think that it's the COVID which is going to be a complication. You need to make sure that you're not getting other bacterial infections, which patients with neutropenia are more prone to. And there is always the question of what we call it as secondary bacterial infection, because if you do CT scans for everybody who's got COVID, even asymptomatic, in about 60 to 70% of people, the lungs will be involved. Yeah. So what you don't want to do is you get secondary infections on top of the COVID viral infection, and then you miss it, or you get an unrelated neutropenia-related infection, and that gives you complications. So I would be a bit more extra careful if you're neutropenic and then develop COVID vaccine, develop COVID infection or asymptomatic.
Fantastic. The next question that we have is about the flu vaccine, and somebody has asked. This is Jen. Hello, Jen. Jen has asked whether can a child with stable, non-severe aplastic anemia have the live flu vaccine nasal spray?
Sorry, Sam, phrase that question again. Apologies.
Of course, yeah, no problem at all. This is from somebody that's asking whether their child who has non-severe aplastic anemia, which is relatively stable, would it be safe for them to receive the live flu nasal spray vaccine?
I think I need to come back on that because I've not seen data with live nasal spray flu vaccine and aplastic anemia. Apologies, I do not know the data, and I don't want to give any wrong answers to that. So I don't have answers for that, but I'm happy to email back to you guys next week after I've done some research into it. I don't want to give something which is totally wrong with this. More so when you're recording it as well. I need to
Of
be
course. Thank you for that, Austin. Again, we've got another question from Ellen here. Ellen is a post-transplant patient, and she's asked, at what time post-transplant could she be expected to have a flu vaccine, and what time period would be recommended for that?
Yeah, so usually post-transplant vaccination does not start until a year after transplantation for aplastic anemia patients. More so, the vaccination schedule will not start until, unless and until you're off your immunosuppression, i.e. cyclosporin and mycophenolate or whatever immunosuppression you're on. And then it also depends upon what time you come off it and when you start the vaccination schedule, because if you're not in the flu season, then you have to wait for the flu season to start. But unfortunately, you have to be prepared for loads and loads of vaccination after transplantation once you come off your immunosuppression and once you don't have complication. You just need to follow the routine vaccination schedule for transplant patients.
Excellent, thank you. We also have a question from Natalie here about the COVID vaccine. Natalie has said that she has had 2 of the COVID jabs as required, and today she's had a booster vaccine, a 3rd primary dose, I should say. After the first 2 doses, she did not develop antibodies. Is it possible that I could develop antibodies after the 3rd primary dose?
Yeah, so that's something important, Natalie, because I'm assuming when you're talking about antibodies, these are you might have done it privately, maybe as a commercial private provider antibodies, because there is not many hospitals who offer, or GP practices who would test for antibodies for COVID. So I'm assuming this is some a commercial antibody, or unless you're in a particular trial where they check your antibodies and tell you that you got antibodies or no antibodies. Yeah. So to answer your question directly, it is possible. Yeah. Because the problem with antibodies, Natalie, is they say positive or negative, but it doesn't work like that. It's the level of positivity as well. So even if you're negative, you might be at the cusp between positive and negative. So they might call it cut off and say you're negative positive. It's never a binary. So what I'm trying to say is it's never a binary thing. It's neither positive or negative, but that's how the report will come out, as positive or negative. Yeah. So it's likely that even if you're at the low level, classed as negative, you might be able to boost it after the booster or 3rd primary or whatever vaccine you have. The second thing, which is very, very important, predominantly for a number of COVID vaccines, is antibody is only one part of your immune system which responds against the vaccines, because your immune system has got 2 different types of immune cells. One are the T cells and the other are the B cells. Yeah. And the B cells are the ones which produce your antibody. But that is what being measured. But we are doing some research, but not in aplastic anemia. In King's, we are doing it on MDS patients, where we are not only checking antibody responses, but we are also checking your T cell responses. So how does your other part of the immune system, because antibody is only half of your immune system. There is T cells which produce immune responses, and they are a different type of immune system. So it could be that you don't have antibodies, but your T cells are super jolly good and they are trying to produce all the immune responses and you're protected against it. That's why sometimes I'll always say, whenever you have these tests of antibodies and other things, you might be falsely reassured that you got happy high antibodies and be happy and do everything without doing all the sort of simple social distancing measures and be careful. The other way around is the results might say you don't have antibodies, but your T cells will be extremely good, but you don't know that, and you get worried and concerned that I've not developed an antibodies as well. So the human body is amazing. It's a question of how much you test and what is being tested and what is being told to you. So if you look at it holistically, the T cells are important as well as the B cells, which produce antibody. And it's the collective work of these immune system which helps to fight against, prevent people from getting severe COVID infections.
Excellent, thank you. We've also got a question from Zoe, who has recently received horse ATG, and she's asked here, how long should you wait after the treatment to have the first COVID vaccination?
Yeah, I think it's an important question, Zoe. I don't think so. We addressed it earlier on. We have said 6 months arbitrarily, and this is a consensus across Europe and also in the States as well. So we've said at least for 6 months after completing horse ATG, don't go into the don't have the COVID vaccination, not just because you will react or something like that, but because we feel that the responses will be inadequate during the first 6 months after you completed ATG.
Excellent, thank you. We've also got a question from Ros here. Again, she just asked if we could maybe clarify the difference between the third primary dose and a booster vaccine. She's saying today that she had a booster vaccine for COVID, and she's currently taking cyclosporin. She's had horse ATG in the past, and she's asked, will she need another vaccine following the dose that she had today?
Yeah, that's a bit tricky, is it? It depends upon how they classed you, because personally, I think quite a lot of aplastic anemia patients, if they're still on active treatment, if they're very close to their ATG, if they're still receiving a very good doses of cyclosporin, I would say anything above 50 or 75 milligram twice a day, I personally, in my opinion, should be classed as the very severely immunocompromised people, and they should have a third primary and then 6 months later have a booster. But the question is about how you were classed in the GP practice, because it's how it's recorded as well, that you might have been classed as somebody who doesn't need third primary and can just have a booster. So for people who've had a third primary, they should have a booster 6 months later as per the current recommendation. For people who've had a booster rather than the third primary, I think that's it until we wait advice from the government of what the next steps are.
Excellent, thank you. Ross has just clarified that she's currently weaning off cyclosporin as well, just to add on to that. Yeah. Excellent. So we've got another question from Marion here, who has non-severe aplastic anemia. She's had both of the doses of the COVID vaccine. She said that she's always been told not to have the flu vaccine, and is that advice different now? I think Marion arrived a little bit later into the session, so we can just go over that.
Okay, sorry. So Marion, I think to answer your question, yes is the direct question. I would probably say not have the flu, because we were having a long discussion earlier on, but essentially it's about the risk, because we always felt COVID is a big killer compared to flu. Yeah. So that's why, unlike what the government said when at the earlier stages of flu, when they said, oh, it's just like a flu, it's not. We have seen it, we've lived through this, we know it's quite dangerous. So it depends upon the risk-benefit ratio. So we felt COVID is extremely risky, complication, can lead to mortality in about 1% of people. So we said the risk of getting COVID is more dangerous than the risk of vaccine giving any complication. But with the flu, we still stick to that advice in the aplastic anemia community in UK, at least, where we've always been a bit conservative because of anecdotal reports and a couple of case reports of flu vaccine making the blood counts worse and causing relapse of aplastic anemia. So I think if possible, if you can, then that's would avoid if you can, is what I'd say.
Excellent, that's great. We've also had a question from Myra here, and this is an incredibly important question, actually, given the fact that people in England who were shielding received a letter just the other day saying that the shielding list has now been abolished. A simple question here: should we continue to shield? And what is the advice now for people that are clinically extremely vulnerable?
Yeah, so that's a bit of a difficult one, is it? Because we never expected this, and then suddenly the government said withdrawal of shielding, and other letters came through just like that. I think so, and I've always sort of stuck to this, saying that I think our patients, it's a bit somewhere in the middle. Yeah, if we can pick up something between no shielding and somewhere in the middle, that's probably where things should stay. You don't need to be totally wrapped up in cotton wool and not have any social interaction at all. But if we can all be sensible and try to do the right things, not to be totally stuck inside the home, but just go around, but be careful, open spaces, and not too many people. So I think it's just to be around, but be sensible is what I would say. So if there is somewhere in between shielding and no shielding, somewhere as a halfway house, that's probably what I would say should be followed, the usual hand hygiene and other things. And I think unfortunately the government thing has been slightly, because people don't understand the mask is not for you, it's for the other people. So I think it feels like the messaging was not right. If they've said you're masking to protect other people rather than to protect you, I don't know whether people would have had a better ability to listen, because they always say, why should I wear? I'm not worried about myself. But it's not you, it's the person sitting next to you who could be immunocompromised and who could be at a risk of it. So that's where the question lies. So yeah, it's a difficult one, but I think we just need to live our lives, but be cautious, be careful, loads of hand washing, hand hygiene, masks, and try to maintain a bit of distance if possible. Yeah, but
Excellent.
don't stop hugging your young children and grandchildren and other things. That's a bit cruel, I would say. Yeah.
Excellent. I'm sure people will be very relieved that we don't need to go back to those early days of locking ourselves in rooms and just opening a window, as the government told us to do at one point. So, yeah, I'm sure that's a massive relief for many of us here. Do we have any more questions? We've still got about 10 minutes left. So please do feel free to put more in the chat or unmute yourselves if you'd like to ask. Excellent. So we've got one from Helen here. Helen has asked, do IVIG infusions affect COVID or flu vaccine effectiveness?
No, I don't think so. It should. Some ways it might be even better, is it? Because what is IV? Sorry, apologies. For people who don't know what IVIG is, for the general audience, it's intravenous immunoglobulin, which essentially means a concoction of protein with loads and loads of antibodies taken from number of healthy people around the world. Yeah. So that will have loads of protective antibodies against number of viruses and number of antibodies against different things. So essentially, I don't think so it should have vaccine effectiveness. But say, for example, if that IV immunoglobulin or protein was collected from 100 people who all have had COVID and COVID vaccination, you're getting free antibodies from other donors on top of whatever the other indication you're getting IVIG for. So it might be even more protective rather than diminishing the effect of vaccine.
Excellent. So do we have any more questions? Lovely. Do feel free to unmute yourselves as well if you prefer to ask them that way as well.
Yeah, I'm happy to answer if somebody wants to unmute or put their hand up, or virtual hand or whatever hand. Mandy, I know you would ask the first question. Need to sort of mention it to them, and I think we hopefully in the next week we'll be sending out letters, at least from King. Some of the other hospitals have started to send out letters as well, and that will have a letter to the patient and the letter to the GP as well, saying that you are in this group, you need to have a third primary, or you need to have a booster, or you need to have the revaccination. I think so hopefully we should have those letters in the next upcoming weeks. I think so. It's never black and white which conditions fall into the group which needs a third primary versus a booster. because the conditions which the JCVI, the Vaccination Joint Committee on Vaccination, says is that anybody on chronic immunosuppression, without giving exact details of what that means. So it is more of an extrapolation. Some people will say aplastic anemia patients who are on cyclosporin should be classed into that. Some people will say no, not really. They should get the third booster rather than third primary. So although the recommendations are there, it's very difficult. Personally, I feel anybody who's still on cyclosporin, be it even a reasonable dose, like anything more than 50 or 75 twice a day, should be classed as that category and should have third primary and then have the booster. But that's my personal take on their recommendation. But obviously, I'm not the person making these decisions. So that's what I feel it should be.
Excellent.
Thanks, Julie. I probably would take whatever is being offered, I think so, because what we've been seeing in patients with immune dysfunction or immune system which is down is that the antibody responses might be better with Pfizer, but it seems to be that the T cell responses seems to be better with AstraZeneca. So sort of if you add those together, it might be that both might have a similar effectiveness, I think so. So I think anything which is offered should be potentially fine, I think so.
We've also had another question from Natalie in the chat here. Natalie's asked, how likely do you think that it might be that AA or PNH patients could receive an infusion of antibodies as a preventative measure against COVID?
Yeah, I think what Natalie is asking is, Natalie, thanks for the clarification as well, because you mentioned that you're on the side and study looking at healthcare workers with antibody checking as well. So I think what, just to expand for people, what Natalie's question is, I'm assuming what Natalie's saying is, so there are a couple of new antibody treatments for COVID, and they're being brought up so this is one of them was the famous one which technically Donald Trump had it when he had COVID. So this is called antibody treatment. And these are treatments predominantly given for people who cannot mount a response against vaccination and or at increased risk of complications when they get the COVID. So those patients, when they get COVID complications and infections and get admitted, they will be given antibody treatment, which was recently, I think about 3 weeks back, approved by NICE, and quite a lot of hospitals do have stock. So this is a new way of treating people who have not had the ability to form antibodies against vaccination or to the COVID infection, that the antibody treatment could help to prevent the complications.
Excellent, that's wonderful, thank you. We also have another question here from Lisa. Lisa has also received a stem cell transplant recently. Hello, Lisa. She's asked what would be considered a low dose of cyclosporin. She said that she's currently taking 90 milligrams twice daily, and the hospital still don't want her to receive her COVID vaccination at the moment.
Yeah, I think, I don't know whether there are other factors like early into transplant or graft versus host disease, GVHD, but I think 90 twice a day is about 180 milligram, and it's sort of relatively a slightly higher dose is what I would say. Just as a rule of thumb, anybody less than 2 or 2.5 milligram per kilogram of cyclosporin per day is more of a lower dose. Anything above that is a higher dose, but there might be other factors, or you might not have reached 6 months or beyond 6 months as well. So there might be other factors as well, but it's just that the reason, I don't know, sometimes people are a bit late in giving vaccination in people who are on cyclosporin to come off is you don't want to get a first dose and second dose and find you've not formed antibodies, and then you don't know it, and then the problem is the cycle starts again. Then you need to have another dose and then a second dose as well. So I think it's slightly erring on the side of caution, I think so. And I'm sure there would potentially could have been other factors which have influenced your physician's decision to delay vaccination. I'm hoping.
Excellent. Lisa's just clarified that this is a second stem cell transplant, as the first one failed. So the team are being a little bit more cautious this time. We also have another question from Kimberly, who submitted it on behalf of a patient who isn't here tonight. If a patient is unable to have their second vaccine after experiencing complications from the first dose, are there alternatives available that could protect them?
Again, I need to see what the literature is now, but my understanding was it all depends upon why the patient could not have the second dose because of the first dose. What complications were this? Because if this is very particular complications related to the vaccine itself, or is it the what we call it as excipients, or the ones which they use to mix the vaccine with, because some of those are the main reasons for people getting allergy. So it all depends on what is the type of complication. Is it an allergic type of thing, or is it a blood clot, or is it a different complication? Because one of the safest thing would be to do is to change the vaccine preparation so that you have a different type of different type of vaccine to be given, and that could technically be touchwood not having the same complications as the first one. So it all depends upon the particular type of complications you've had.
Excellent. Thank you for that, Austin. Obviously, as everybody can see, we have about 2 minutes left. So if we have any final questions, if you could either unmute yourselves now or pop them in the chat, then we can maybe just finish off with one more question if there is one.
I think there was one question which we might have missed, but we did touch upon, just asking, are there people with AA getting a good response to vaccine?
Yes, that's right.
That data is pending. The Leeds team are looking at the vaccine response to a cohort of aplastic anemia and PNH patients, but the data is still not out there. But as I said earlier on, my guess is a totally random guess, but I hope it's an educated guess, that around 60 to 70% of patients with aplastic anemia and PNH would definitely form antibodies based upon data from other conditions where immune system is suppressed.
That's wonderful. Thank you very much, Austin. I think we can safely say that we can wrap up there for tonight. I'd again, on behalf of the community and the AAT, thank you so much to Austin and for Simon for joining us this evening. That has been a very, very enlightening question and answer session, and I'm sure our community too have found that really useful. So thank you very much for that. And of course, to everybody else that's here tonight, if you have any more questions, do feel free to send them in to us at the AAT, and I'm sure we can pass the odd question on to Austin or the team, and they'll be very happy to help. So have a lovely evening, everybody, and thank you so much for joining us. Goodbye.